Hello, good evening, everyone, and thank you for coming to the webinar with Dr. Visvalingam. She's a psychiatrist at Putrajaya Hospital. I'm Dr. Kartini, and I'll be your moderator for tonight and co-hosting with Kenny as well. So Dr. Visvalingam is a consultant psychiatrist at the Department of Psychiatry and Mental Health Hospital Putrajaya. She has been involved in several national and state-level projects within the Ministry of Health, Malaysia, including developing frameworks and guidelines, as well as training pertaining to mental health services in Malaysia. She actively gives talks for public and government agencies in various aspects of mental health, including stress management, suicide prevention, psychosocial response in disasters, and other mental health aspects. She strives to work with the community, including schools, to create awareness in promoting mental health and educating the community in prevention of mental health issues. And since stigma is a huge hurdle when dealing with mental health, she believes that by constructing interagency programs to create platforms for dialogues and open discussions, we can handle this. This would be addressed in a more holistic manner. She's a life member of the Malaysian Psychiatric Association. So before we start the session, I'd just like to remind everyone that we are a suicide prevention center, which is non-government, which is a non-government association, and we actually depend a lot on donations. So if anyone would like to donate, please do so. You can just scan the QR code, and for donations above 50 ringgit and above, we would be able to give you proof of transaction so that you get some leeway from the taxes. Also, we are recording this session so that just to remind everyone. So thank you, everyone. And Dr. Uma, please do start. Let's put our hands together for her.
Thank you, Dr. Kartini, for extensive introduction. Good evening, everyone. I hope everyone can hear me. Okay, thank you for coming to this session, and I would like to thank Befrienders for giving me some space to share a little bit of knowledge on, suicide prevention. Okay, and also to create awareness on suicide prevention. Okay, actually, this is what we are striving for, to expand our awareness, awareness among the community about suicide prevention, and also break down the taboo, break down the barriers and the stigma related to suicide and suicide prevention and mental health issues as well. Okay, shall I share my screen, Dr. Kartini?
Yes, please do start, Dr. Uma.
Okay, everyone. All right. So we will start with the theme, okay, our World Suicide Prevention Day theme. This is actually a triennial theme, okay? For 3 years, we are using this theme. It's called Creating Hope Through Action. It's from, we are using this theme from 2021 right up to 2023, okay? So in Malay, it's actually called Bertindak, Segera, Harapan, Terbina, okay? So a little bit, okay, a small reminder to our participants here. Okay, we just want to let you know that discussing about suicide, it's never an easy topic, okay? It may trigger certain unpleasant emotions, especially those who have lived experiences, those who may have lost a loved one to suicide, and those who may be having suicidal thoughts. If you feel uneasy, you may take a break, call a helpline for support, or seek professional help from the numbers that we will project later. Okay, so it's just peringatan lah untuk semua orang bahawa perbincangan tentang bunuh diri mungkin boleh mencetuskan emosi yang tidak selesa. Okay, so kita galakkan jika kita rasa tak selesa sewaktu sesi ni, kita mohonlah tuan-tuan dan puan-puan untuk menghubungi talian bantuan atau boleh memohon untuk mendapatkan perkhidmatan profesional daripada kita akan paparkan nombor-nombor bantuan selepas ini, ya. Alright, like I mentioned before, creating hope through action, okay? Our International Association for Suicide Prevention, or the IASP, it states that this theme acts as a reminder, okay? Sorry, can I close this or? Okay, it acts as a reminder, okay, that there is an alternative to suicide. And this theme also aims to inspire confidence and light in all of us, okay? It's actually to tell people who are experiencing suicidal thoughts, there is hope, okay? And we are here to support you, all right? So we need to create this awareness, and we need to reach in to those people who are struggling. So however small or however big our actions are, we hope that our small actions may provide hope for those who are struggling with suicidal ideas or having suicidal behavior. Okay. All right. Every suicide is a tragedy. Okay, the impact on families, friends, and communities is devastating and far-reaching, even long after the persons dear to them have taken their own lives. And this was quoted by Dr. Margaret Chan, our former Director General of World Health Organization, and she had actually visited Hospital Putrajaya when she was during her tenure. So we were very blessed to have her visit us, and this is what she had quoted. Okay. When we talk about suicide, actually it's related to, how much does the community, how much are they aware, of suicide? Right? So we know that, I think we are well aware that awareness on suicide prevention is low. But why? Okay. Number one, stigma. Stigma. All right. So the stigma related to help-seeking behavior in those who have suicidal behavior or those who are experiencing suicidal thoughts. Okay, they are ashamed to come forward because they feel that there's negative attitudes towards mental illness and suicidality. So for that very reason, okay, we should start talking a little bit more on suicide prevention. Okay. The more we talk about suicide prevention, it actually encourages those who are having suicidal behavior and suicidal thoughts to seek help. Okay, many still do not know where to seek help and what to do. Okay, so therefore, at the end of this presentation, we are going to show a few numbers, okay, or contacts or helplines that people can actually reach out to, okay, to help them. And there's also lack of awareness of the existing risk factor. There's a lot of risk factors to suicide, which contributes to suicide within the community, and not many people know about it. And recently after the pandemic struck us, okay, we have the economic downturn, people losing jobs, okay, there's increase in domestic violence. All these are social factors which actually contribute to increased in suicidal behavior. And there's a lack of awareness because everyone is working in silo. Actually, the truth is all these factors, there's an interplay on all these factors which actually contribute to increase in suicidal behavior. All right, let us discuss about common myths, okay, about suicide. Okay, so beberapa mitos berkenaan dengan bunuh diri. Okay, people have actually asked me, saying that how do we know whether that person has suicidal thoughts? Some of them don't even express, and suddenly the next thing I know that he's hurt himself. All right, so we have to let you know there are warning signs. Okay, many people think that suicide occurs without any warning, but let me tell you about the warning signs, okay, that we actually see in people who have suicidal behavior or who are experiencing suicidal ideas, okay? All right. There are several, we can actually categorize them, okay? They may actually directly verbalize about their intention, to hurt themselves or to take their lives, okay? They may talk about having unbearable pain, okay? They may also refer to them as, I'm being a burden to my family, okay? Saya membebankan keluarga saya, okay? When they start talking about this, these are actually verbal warning signs. They are red flag signs for suicidal intent or suicidal behavior, okay? Someone who expresses that he or she has no reason to live, or they directly say, I'm going to, talk about killing themselves, okay? Though these are direct verbal red flag signs, okay? What about the direct non-verbal warning signs, okay? You may actually see people who are very jovial, very cheerful, they are very productive, interacting well with people. Suddenly they start isolating themselves, or they start exhibiting what we call loss of interest. Okay, in psychiatry, we call it anhedonia, which is another symptom of depression. Okay, they used to watch TV, they used to, play football with their friends. Okay, they used to hang out with their members in cafes, talking about stuff. But suddenly, when you call them, say, no, I don't feel like doing this. I don't feel like going out. Isolating, menyendiri. Okay, and then they start talking about feeling helpless, hopeless, or worthless. Okay, some of them may even display severe emotional pain or distress. Okay, you can see from the way, they can be easily angered. Okay, they have crying spells. Okay, and they can also exhibit, they can show signs like writing a farewell letter, saying goodbye. Okay, so these are non-verbal indicators of possible suicidal behavior. What about indirect non-verbal? Okay, they may not express it, directly, but they will start looking for ways to end their lives. There may be increased use of drugs and alcohol, and they start withdrawing from activities. They may start giving away their possessions, and also we may see an increase in agitation or irritability. So these are what we call indirect non-verbal signs. So suicide does not occur most of the time. I would say it does not occur without warning. Okay. The second myth, okay, mitos yang kedua. Apabila seorang tu mengalami idea untuk bunuh diri, seseorang tu akan mempunyai idea untuk bunuh diri untuk selama-lamanya. Okay, so we feel that some of them actually feel that once they are having suicidal thoughts or they've exhibited suicidal behavior, they will always remain suicidal for the rest of their lives, which is actually untrue. Okay, there's a study, and this is evidence-based. Okay, it says that the acute period of heightened risk for suicidal behavior is often only minutes or hours long. And this is done by Horton in 2007, one of a landmark study, okay, where we call it suicide crisis, okay, suicide crisis. I'll just show you a little small graph. So this suicidal crisis, we can actually see this duration of suicidal crisis. A person can be stable for years, right? But however, when there is a trigger, okay, but it all boils down to how resilient the person is or how good their coping skills are. So that's why when we talk about this, right, when someone has been stable for so long and then suddenly, there's a crisis, immediately they may exhibit suicidal behavior. What happens actually? So the crux of the problem is, when you look deep into the matter, it starts with, they are building up their resilience and also their coping mechanisms or their coping strategies. Okay, if they have very shaky coping strategies, even a small trigger. All right, so we cannot generalize. Hey, how come this person is able to cope with this current situation, but the other person B cannot. Okay, so look at the intrinsic factors, intrinsic personality factors. Okay, so they may have this person who has, easily succumbs to triggers in the environment or, life events. They may have, maybe some anxious personality traits, or they may not be, know how to cope with certain situations or adverse life events very well. Okay, so even a small trigger, even a small trigger can start a crisis. So when the crisis starts, it peaks from within days, hours to days. This is the highest risk, where the suicide crisis peaks. Okay, so if we intervene, during this time, we are able to detect the early warning signs, or we are able to detect the red flag signs of possible suicidal behavior. We can have, we can actually intervene and encourage them to seek professional help. Okay, and when we do that, they may call a helpline, or see someone for that. Okay, so it actually, the crisis may reduce, and if the intervention persists, the person may return to their stable mental state after that. Okay, so this is what we call the suicidal crisis. So it's nice to understand, because suicide crisis doesn't occur over a span of months or years. All right, it peaks and it reduces. So it's a very temporary crisis. It's a very temporary situation. So what about the third myth, that we're going to discuss? All right, it says that suicide only affects individuals who have mental illness. Okay, I receive several questions about this. Yeah, doctor, he never had any mental illness, but then how? What happened? Okay, so again, this is evidence-based. Okay, so I'm always talking about evidence-based findings. Okay, suicide is not caused by a single factor. It's an interplay of several factors within the community, their personality factors, their environment, their family dynamics. A lot of factors have, play a role in tipping a person to having or exhibiting suicidal behavior or having suicidal thoughts. Okay, so studies have shown that many people, I would say a lot of people who die by suicide, are not known to have a diagnosed mental health condition at the time of death. Okay, so this is something I would like to share. All right, so not everyone who has suicidal ideas or exhibits suicidal behavior has mental illness. Okay, they may have, they may be experiencing a crisis at that time, but like I said, if they have certain personality factors or their resilience or coping strategies are not optimum, it may contribute to that person resorting to suicide as a coping mechanism. Okay. This is very commonly asked if during forums, even during our sessions in the clinic. People would, parents would say, doktor, jangan tanya pasal ni ya, dia cuba nak cederakan diri, kita risau dia akan buat sesuatu kemudian. They always say that, a lot of people actually say that talking about suicide will encourage suicidal behavior. Okay, I mean, when we do assessment, we have to talk about suicidal behavior for us to elicit the risk factors, and for us to actually stratify a person, whether they are high risk, they are moderate risk, or whether they have low risk. So we have to ask a person about suicidal thoughts, their intent, on killing themselves or harming themselves. Okay, we have to ask all this. This is definitely a major myth, because evidence shows that asking about suicide is actually protective. Okay, what we need to do, even asking, when you ask a patient or a person about their suicidal thoughts, it gives that person space to express their distress. Like I said, talking about suicide is a taboo. So even someone who comes to, your friend, you feel that they appear to be in distress, and you may suspect they may have some suicidal thoughts, okay, or suicidal behaviors. Okay, you may have seen signs to say that they have tried harming themselves. Okay, how do you ask? The thing is, they are afraid to express their thoughts because they may be discriminated. Okay, stigma, discrimination among those having mental health issues, those having suicidal behavior is so high. Honestly speaking, over the years, being a healthcare provider in psychiatry and mental health, even we are discriminated, to honestly speaking, right? Because, as far as I can remember, when I was a medical officer in the hospital, when we came to the other wards, not our psychiatry ward, when we visit the other wards to see our patients, having mental health issues, we get snide remarks, okay, from the other healthcare professionals. Okay, some of them we have actually heard some of the nurses saying, "Oh, Dr. Gila dah sampai." Okay, so even we are discriminated. All right, so we need to advocate for our patients. Okay, so we are the right people who are working in mental health services. We need to advocate for them, right? So by asking about suicide, the first thing is always to ask. Okay, ask someone, be there, all right, make sure they are safe, and link them to proper services. And this is what we need to do. Okay, when we ask the person about suicidal ideas or suicidal thoughts, okay, or ask them about their suicidal behavior, it gives the person permission to tell you how they feel and make them realize that they are not a burden and they are not alone. Okay, so our role is to validate. We don't give them solutions. Maybe we are not in a position, some of us are not in the position to give them solutions, right? But we can actually guide them, to help them, to seek professional help or seek appropriate help. Okay. When we reach out, we reach into these people who are struggling. They may not have healthy coping mechanisms or a strong support system. So they may even have expressed their suicidal intent. In fact, I have people coming to me during my session in clinic, patients coming. They have actually told me, "Doktor, saya pernah beritahu mak ayah saya bahawa saya ada ideas untuk bunuh diri dan niat untuk cederakan diri itu sangat tinggi." Okay, tetapi mak dengan ayah saya meremehkan or they downplay what the child is actually telling them. So what happens when this happens, when they get their doors closed, all right, they are trying to seek help, but their doors are shut in front of their face. Okay, they tend to clamp up. All right, so they start they start repressing what they are feeling, and for fear, people will start discriminating them. Even we have comments like, "Oh, you have to be stronger than this. You having suicidal thoughts, or feeling anxious or feeling depressed is only for the weak." Okay, which is not true, right? So many have actually admitted feeling relieved when they start talking about it, and we start listening in a non-judgmental manner, okay, and we start validating what they feel. If we have not experienced suicidal thoughts or suicidal behaviors or had suicidal behaviors, we cannot say that I understand what you're feeling, all right, because we've not been through this. All right, they may just turn around and say, "Doktor, you tak pernah rasa macam mana saya rasa." Yeah, which is true. Okay, or even when you've lost someone, okay, when someone comes to you, you're doing grief counseling, we never say, "Saya faham, okay, I understand what you're going through," because you may not feel the same way. But you can always say, "Yes, I understand this is a difficult time for you. Okay, and let us see how we can help you." All right. So when they start talking about it and you do not downplay their symptoms, they actually feel very relieved opening up. And this is what we want. Okay, so some of them actually come and say, doktor, jika dia perkara ni berlaku lagi sekali, jika dia datang jumpa saya, kata, mak, saya rasa macam ni. Okay, mom, I have ideas to hurt myself. Okay, what do I need to do? Right? Or they may not exhibit. They may be isolating themselves in the room. Okay, but these are, like I said, these are warning signs. All right, they don't join or they don't interact with the family members. Okay, they're isolating, they're withdrawn. Okay, how do you start? How do you ask about this? You may start with, I have been feeling concerned about you lately. How long have you been feeling this way? Okay, and have you been feeling so badly lately that you have thoughts about harming yourself? Okay, so in a gentle way, right? So when you open the door, people would want to talk about it. Okay, most people do. All right, but if the individual has expressed intention to hurt himself or herself, okay, you can say, I understand that this is difficult for you, but taking your life is not the way out. Okay, then you proceed to saying that, okay, I can link you to professional help, or you can call this helpline, right, to express your thoughts. Okay, so what is the fifth myth that we commonly, we commonly encounter, right? The myth is it says that you cannot help a person who has serious suicidal thoughts. Is it true? Okay, then why are we having this session? This is actually to create the awareness, saying that help is possible. Okay, there is hope, right? So we do not just want to say, okay, someone has serious suicidal thoughts. Okay, I don't want to look at you. Okay, we can't do that. Reach out and talk to them. All right. Sometimes if you do not have or you do not know what words to use, just be present. If the person has intention or has already hurt themselves, please be there, be present, make sure the person is safe, and call for help. All right, by talking to someone who has these thoughts, it makes the person feel safe and validated, and being validated is so important. Okay, we have people who have tried to reach out to their friends or their family members, but since their family members or friends do not know how to tackle, or they feel, oh my gosh, I do not know what to say, right? They start avoiding that person. Okay, so even if you don't know what to say, just listen to them, be there, be present, and try to validate what they are telling you. So help them know that someone cares and support is available. Okay, that's the most important thing. So most of the time, like I said earlier, active suicidal thoughts are only temporary. The situation can be changed if the person could be helped during that wave of crisis. So getting the right kind of support at the right time is so critical. Therefore, we need to equip ourselves with, okay, what sources of help do I can reach out to? Okay, who can I call? Where can I call? During office hours, what are the available help that I can access? Okay, after office hours, where can I go if I do need help during a crisis, right? So like I said, if they have already tried harming themselves, please call for help immediately, but be present with that person and make sure that person is safe. Okay. Some of them say, I have patients who come, parents who come and tell me, doctor, I feel that he or she is just trying to seek our attention. I don't think she's actually seriously has intent to hurt themselves or kill them, take their lives. Okay, they are not seeking attention. We have to get rid of that thing out of your mind. Okay, we cannot say that person is seeking attention. Anyone who expresses intention to end their lives should be taken seriously. Okay, we cannot say that, oh, dia acah-acah je. All right, we cannot say. There's no acha-acha here, because you cannot, even when we assess, we healthcare professionals, when we do assessment of someone who has harmed themselves, okay, in the emergency department, we cannot rely on any objective tools, because the bottom line is actually we do not use tools, okay, to assess, okay, do you have suicidal thoughts? Yes, no. Do you have this? No, it cannot. We have to engage with that person, okay, we have to establish a good rapport with that person, and we have to use our clinical judgment, okay. So we cannot say, why are they coming? Why do they keep coming to our emergency department? You know, we have done this gatekeeper training for our nurses in the emergency department, to let them know that anyone who comes with self-harm should be taken seriously, even though they come with repeated self-harm. Be serious, okay, and talk to them seriously, validate what they are saying, what they are telling you. No one wants to come to the emergency in the middle of the night, okay? Why are they coming? It could be a cry for help, okay? They want something. No one wants to come 2-3 times a week in the middle of the department to a crazy emergency department and wait for hours just to see a doctor. No one wants to do that, okay? So what are they trying to tell us, right? So that is what we have to establish, and that is what we have to assess. So once we do that, okay, we say that this is a serious matter, help them get the right support. So getting the right support at the right time may save their lives. Very important. Okay. So like I said, bottom line is you have to ask. Okay. Ask them, be present. Okay. Try to validate what they are saying. You know, make sure that they are safe, and link them to proper resources or proper help, proper professional help, so that their problem is looked into. So actually here I have prepared several resources, you know. So when we do this kind of webinar or forum, we try to disseminate whatever resources we have, because when we ask people, why didn't you, you could have, you could call a helpline. Okay, doctor, what helpline do I have? You know, some of them don't know what's out there. I think 80% of people who I've asked, they know Befrienders. Okay, so Befrienders, you're doing a great, fantastic, awesome job. Okay, disseminating the resources and or in your services. But a lot of them don't know that all government clinics can do mental health screening. Okay, all major hospitals around the country, nationwide, provide psychiatry and mental health services. We have what we call a community mental health centers across the nation, where a person can actually come in without a referral letter. You don't need a referral letter, because a lot of them say, doctor, it's so difficult for us to go to the GP or go to the clinic kesihatan to get a referral letter just to come to seek mental health services. You know, when you can actually walk in to a community mental health clinic, or what we have termed them as mentari. Okay, there are 25 at the moment, 25, 26 mentaris nationwide, right? It's within the community. You can walk in, you can do screening, and if possible, you can meet the doctor on the same day. Like for Mentari Putrajaya, you can meet with the existing staff that we have. You can meet the doctor based on your screening that we have done for you. And you do not need a referral letter when you walk in to a community mental health center. But for the psychiatric services, for the specialist psychiatric clinic in the major hospitals, you will need a referral letter, and the referral letter can be got from a clinic kesihatan or a government health clinic or a GP. Okay. So a few of the resources that we have. The other thing that I just wanted to add that, among the resources that we share with, persons who, tend to come with self-harm behavior or suicidal thoughts, there are apps, mobile apps that you can access. There's one mobile app, which is called Safety Plan, right? So this safety plan, Hospital Miri has come up with a black and white. We call it a safety plan for suicide, where when we discuss, when we see a person who has exhibited suicidal behavior or has suicidal thoughts, we would do the suicide plan, where in that suicide plan we name resources. So in the times of crisis, they can look at the suicide plan, because at that point in time they just their mind is, they are in a bubble. Okay, they feel so helpless. They are what we call buntu, they just have, they feel hopeless and they feel helpless, and they do not know where to go. So when they open up that suicide plan that we have discussed with them during the session, they open up the resources, the contact numbers are there. So immediately they can just call up the contact numbers, or they can call up the helplines, which we have actually written there in the suicide safety plan. Okay, so among the resources that we have, okay, this is available in our Ministry of Health Malaysia website. We have a list of government and private healthcare facilities that we can access. Okay, anyone can access. So, and they tell you, they detail helplines available. Okay, there are multiple. These are only a few helplines that we have, written there, exhibited here, but there are multiple helplines that people can access to. All right. So there's a database on the left side is Klinik Kesihatan, the list of Klinik Kesihatan. I will show you a QR code that maybe, I think Befrienders has already put it up on their website before last year, if I'm not mistaken. Okay, this is what we call Talian Kasih by the Women's and Family Development Ministry, right? Ministry of Women and Family Development. Okay, so if you suspect any abuse, and you need counseling, you need what we call child protection. Okay, there's several things. Pembuangan bayi, okay. There's also a child helpline that we can contact, and this is the main helpline, Talian Kasih, which is 15999, where someone can actually call to access help. Okay, like this is what I was saying, right? This is a program by Ministry of Health Malaysia, which is called Let's Talk Minda Sehat. So the talk stands for T, tell someone you trust about your problems. A is ask for help. L is listen without judgment. And K is know where to seek help. So these are the several QR codes, okay? MHPSS stands for Mental Health Psychosocial Support Services. Okay, so we have several helplines that you can also call. This had actually been this started during the pandemic, where we, MOH was getting several calls about asking about the pandemic, about COVID and all that. So we MOH came up with this helpline, okay, these helplines with Mercy Malaysia to, encourage people to call in, whenever they are faced with any psychological difficulties, right? So here we have Talian MHPSS Negeri, we have Senarai Perkhidmatan Psikiatri, okay, in the major government hospitals. We have Senarai Klinik Kesihatan, and also we have the NGO Mental Health and Psychosocial Support Services. Okay. All right. So the other thing that I wanted to highlight, the last 2-3 slides, in your My Sejahtera, okay, the Ministry of Health has, if you access to this, this is your homepage lah, okay. This is the homepage for My Sejahtera. There's this little 4 buttons here, right, which says more. So if you click on that button, you can get this page, all right, which says, I think there's another page that, yeah, okay, you come up with this, okay, this page, right? You see this page which says Minda Sehat, and also clinic appointment bookings. So these clinic appointment bookings are for the government health clinic. So you can book your clinic appointments through this system. Okay, they have two systems here. So when you open this, you can actually choose your health clinic and you can book your appointments through this system. And this Minda Sehat, okay, there are several things. Okay, when you click Minda Sehat, there is emotional support helpline, there's psychosocial support information, there's mental health information, and also self-screening assessment. Okay, so we hope that there's also a tab on organ donation. Okay, so I think recently, yesterday, that I heard on the news, on the radio, over the radio, that the number of donors have increased through this app. Okay, so My Sejahtera has a organ donation app, so you can actually pledge to donate your organ through My Sejahtera as well. So they have actually, refurbished all the functions on My Sejahtera. Okay, so I think these are the few resources that we have. Okay, so I hope that helps you access help. Okay, so back to you, Dr. Kartini. I hope it was
Right.
clear. Yeah.
Thank you, Dr. Umar. It was very clear, and we managed to get all the contact numbers.
Oh, great. Okay.
That we needed to get. And I also didn't know that actually people could just go to any clinic kesihatan, because I was under the impression that they can go to the Mentari only.
Okay.
I wasn't sure. Didn't know that now all the clinic kesihatan have been empowered to do mental health assessment.
Yes, they have something called Saringan Minda Sehat lah. Where so they do this depression, anxiety, and stress scale. Then we can actually, like DAS 21, it's called DASS 21, where I think there are several online versions lah for DASS 21. So I think a lot of people who walk into Mentari have already done their DAS 21 screening. So they tell us, these are my scores, my stress is severe or very severe, my depression. So if they come with very severe and severe, we will always intervene there and then, right? So depending on the severity of their screening. So when they walk into Mentari, any Mentari, our nurses will do a screening. So we offer them the DAS 21 and they will do there and then. So based on that screening, we will either refer them to the doctor immediately or give them an early appointment. So far in Mentari Putrajaya, we've been actually seeing patients on the spot. Okay, with the available resources that we have, the human resource we have at the moment, we are able to cope with walk-ins. So I can't speak for the other Mentaris because their system may be a little bit different, but I can only speak for Mentari Putrajaya. So we make it easily accessible because, like I said, taboo, stigma, right? So that's the main reason the mental health, the community mental health services was created in the Mental Health Act 2001 for this sole purpose, to reduce the stigma, to increase accessibility within the community. So we need more people to reach out. Even if someone says, I think, but I'm not sure, should I go, should I not? Just come for screening. Just come for screening. If your screening is fine, then you are assured that you are okay, you are doing well, right? So no harm in coming for screening. Okay.
Oh, I've one question. What kind of services for psychiatric patients do you have? Like, do you also offer like clinical psychologists for those who are not serious? It's not just all medication, right? Because there will be other
it's not
support.
agreed. I totally agree with you, Dr. Kartini, because not everything, based on what illness you have lah. Okay, what illness someone has. If we feel that, because we have counselors in the hospital, we have clinical psychologists, but clinical psychologists, I think to date, we have only 46 clinical psychologists within the Ministry of Health, and it's dwindling. Okay, I think most of them, they prefer to leave, and because I think the pastures are greener outside. The grass is definitely greener outside, but in government services, very sad to say that we do not have that many clinical psychologists. Like in Putrajaya, in Hospital Putrajaya, we have 2 at the moment, so we are able to cope. Because if we feel that the all patients do not go straight to see the clinical psychologist. They go through us. So the doctors will do the assessment, their history taking, clinical assessment, their mental state examination, and depending on that, we will do the necessary referral. If we feel that the person needs psychotherapy rather than pharmacotherapy or medications, then we will get an appointment with the clinical psychologist. Or we refer to counselor for coping skills, for social skills, for crisis intervention. So counselors will handle this. For family sessions, marital sessions, couple counseling, counselors handle this. And we actually have a lot of counselors out there. Ministry of Education, we have, even in the civil service, we, our public service department, we have counselors within the public service department. We have counselors in the private. So if they feel that they are unable to come to the hospital or the appointments are very long, we can actually offer them, the choice of meeting a counselor in the private, or a clinical psychologist in the private, So, accessible. So we're talking about accessibility of mental health services here.
Actually, I've run out of questions.
Okay.
And would anybody like to ask any questions? You can also type in the chat box.
Yeah. So if anyone wants to, even don't be afraid to, talk about our own challenges, our own, difficulties. Yeah. Right. Okay. From Mr. Kenny, yes. Bilakah seseorang perlu berjumpa dengan pakar psikiatri? Wait, let me just open this. Okay. Bilakah seseorang perlu berjumpa dengan pakar psikiatri untuk mendapatkan bantuan? Ada yang rasa takut mungkin kena makan ubat sepanjang hayat. Ada juga yang takut dengan kesan sampingan pengambilan ubat. Okay, so what's my opinion on this lah? Right? If you feel that, my suggestion is that, like I said, we have warning signs. Okay, when we want to screen for depression, right? There are only two questions that we can actually ask ourselves or ask people around us, right? Do you have low mood and do you have loss of interest? Okay, so these are the significant two warning signs that we can actually ask ourselves or ask people. If we feel that your mood is not as how you are, it was before, you feel that suddenly you find yourself withdrawing from society, from your family members, you've just lost interest in meeting people, doing things that you like, and having loss of appetite, or having disturbed sleep. All right, you may just have disturbed sleep. Okay, you can still come to see us even if you have insomnia. All right, so walaupun kita rasa macam simptom tu sangat remeh, okay, no harm. Bila kita datang jumpa dengan pakar psikiatri atau kaunselor ke untuk mendapatkan perkhidmatan kesihatan mental, kita tidak akan marah anda lah. Okay, kita tak akan remehkan gejala yang anda alami. Okay, so jika kita rasa kita perlu jumpa, okay, bergantung kepada gejala yang kita alami, atau kita rasa sebelum ni kita produktif dekat tempat kerja, tetapi kebelakangan ni kita nampak macam prestasi kerja merosot, atau kita nampak anak kita atau anak buah kita, okay, budak yang masih bersekolah lagi lebih menyendiri, dan kita nampak prestasi akademik mereka menurun. These are signs, because children would not express, they do not know how to express that they are feeling sad. Okay, children would express it in a different way. So you may find that they are less cheerful, they are less interactive, academic goes down, okay, and they tend to isolate themselves. So these are warning signs in children that you have to look out for. So in school, the teacher may not, because there are so many people so many children in one class, they may not know that, they may not identify that the child's performance in school is deteriorating. So we as parents, or we as uncles or aunties, please keep that in mind, that the children's method of exhibiting depressive symptoms are totally different from an adult expressing their feelings of feeling low or depressive symptoms. Okay, right? So, taking medication, the good news is mental illness is so treatable. We have a vast range of medications that we can use with, what we call is a better side effect profile. Not many side effects, tak banyak kesan sampingan. Kita sering kali jumpa dengan pesakit yang putus makan ubat because mereka dengar kawan mereka kata, bila makan ubat nanti rosak buah pinggang. Okay, so we always encourage them, talk if you have side effects. Okay, you have side effects to medication, please tell us, because kita ada banyak lagi pilihan ubat yang kita boleh pilih untuk anda. Alright, so jangan risau, ubat bergantung kepada kesihatan atau penyakit mental yang anda hadapi. Bergantung kepada penyakit mental tu, ubat tu adalah rejim ubat tu adalah sangat berlainan. Okay, untuk depression ada tempoh-tempoh dia. Okay, so bergantung kepada individu juga. So, tak semestinya ubat harus dimakan untuk selama-lamanya atau untuk sepanjang hayat. Tetapi untuk masalah kesihatan mental seperti skizofrenia atau bipolar disorder, atau delusional disorder, kemungkinan besar, okay, ubat yang kita ambil adalah untuk jangka masa panjang. Okay, tapi for depression, we have a time frame. For anxiety, depends on other factors. If there's ongoing stressors, there are ongoing life events that can actually contribute to your depressive symptoms or anxiety symptoms, we prefer to give medication for a longer period. Okay, but there's a time frame and you will come for periodic assessments to the clinic. Okay, so there's one question. Sorry, Dr. Kati, where did I read? Okay, from Kiranjit Kaur. Thank you so much for your question. Okay, Dr. Kiran, okay. Can you address how to deal with stigma associated with seeking help for mental health issues? Okay, like I said, the bottom line is always about awareness. Okay, talking about mental health issues, talking about suicidal behavior, talking about mental illness per se, there's always a strong stigma. Like I said earlier, that even we as healthcare professionals in the mental health profession are also discriminated and also stigmatized. Okay, they feel that our job is not as serious as a surgeon's job or a physician's job. Okay, so you're just using your mouth and your saliva and nothing much. There are no tools, right? But it's so that's their perception, right? So even like I said, awareness, we need to step up the awareness within the community, and it's various levels. So when we talk about awareness within the community, it's at different levels. Okay, so prevention, preventing suicide is also one thing. We have to create awareness on preventing suicide, different levels. Okay, in schools, within the among the employers, and also media, on safe and unsafe reporting. Okay, so we need to equip certain communities. We need to equip the community when we talk about stigma, mental health issues, right? We don't look, that's only on the surface. When we talk about creating awareness, we need to talk to community about practical issues and helpful resources. So going back to the nitty-gritty of things, we don't need to talk about schizophrenia, we don't need to talk about depression on the whole and looking at how you treat depression. No, the community has to know what are the resources available, okay, and how do we build resilience and coping skills within the community. So when we use that approach, right, it infiltrates to a larger population base. Okay, so I guess raising awareness is the main thing that we have to look at to reduce stigma within the community dealing with mental health issues or suicide prevention. I hope that answers your question, Dr. Kiranjit. Okay, shall we go to the next question? Again, Dr. Kartini? Do we still have time?
There's someone who raised his hand. It's called iPhone
Yes.
016, but would that person want to ask a question, or is it by mistake?
Yeah, you can. Yeah, you can unmute yourself and ask a question. Can? Or shall we? Yes, Mr. Fazli. How are you? Do you have a question, Mr. Fazli? Yes. Hi, Dr. Uma. Okay, about pill medication. Is it still safe to retake it after missing to eat it for a couple of months? Okay, right. Okay. Okay, depending on the medication, you see, because once we have taken medication for a period of time and someone maybe fails to take it, maybe they forgot or they did not have time to run to the clinic to replenish their stocks, okay, we actually encourage them to give us a call first before restarting, because depending on your dose, if we are on a higher dose, we do not encourage that person to restart back on that higher dose, because it may give what we call side effects to that high dose. So we need to gradually taper it upwards. So the best is, if we are not sure on what dose to start, give us a call. Right, so when you call us, discuss with us, or come and see us, we can actually discuss how you can restart back your medication regime. Okay, so it's not safe if you're on a high dose of medication. It's actually not safe to start back after a period of a couple of months. That's pretty long. But if you have missed 1-2 days, then it's fairly safe to actually retake the current dose that you're taking. Okay, but depends on your medication lah, because certain medications, especially for medications, when we give medications for treatment resistant schizophrenia, okay, there's some medication which is called clozapine. Okay, if someone has missed out on clozapine for at least 2-3 weeks, we need to start back on the very small dose because of their side effects, right? But if you're taking antidepressant medications, because antidepressant medications, their aim is to actually boost up your serotonin levels in your brain, in your synapses. So if you have been taking a high dose and you stop medication for some time and you retake back this high dose, your body goes into shock and something called an overload of serotonin in your brain. So we call it serotonin syndrome. So you may have, it's not fatal or anything, but you may have unpleasant side effects. Okay, and that may actually tip that patient into not wanting to continue medication anymore. All right. Okay.
Got it. Thank you so much for answering the question.
Thank you, Fazli. Hope
No
you're well.
problem.
Okay.
Yeah,
Good.
I'm doing well.
So glad to know that. I'm following you on Twitter.
Excuse me, you're following me on Twitter?
Yes, Fazli. I love your
Well,
post.
oh my God. Okay, yeah. I hope you're doing well as well. Are you still
Yes.
serving at the hospital?
Yes, I am, Fazli. Thank you so
Okay.
much for joining in, Fazli.
I just saw the announcement by Befrienders on Twitter and I just rushed in. So yeah.
Okay.
Okay.
Missing you. Maybe we should meet sometime. Okay. Thank you, Fazli.
No problem.
Okay, there's another question from Miss Amina from Befrienders KL. How can I tell the person who attempted suicide won't try to do it again in future? Okay, the other question is, a student told me she needed professional help, but her parents do not allow her. I don't think it's right for me to call the parents. How do I approach this issue? Okay, okay, let's go back to the first question, right? How can I tell a person that they would not? It's a bit difficult, okay? Even for us as mental health care professionals, it's a bit difficult to assess someone. We cannot say this person will not attempt to hurt themselves again or won't try to, harm themselves again. But our assessment has to be very stringent. Okay, so it's for someone who feels that they are not, they do not have the right training or tools to assess someone, please refer them to a proper mental health care professional for a proper assessment. Like I said earlier, even someone coming to our emergency department, those days we would write contracts, we would have contracts with our patient. Contracts don't work. Okay, in times of crisis, they feel that extreme hopelessness. Okay, and you cannot say, in actual fact, you cannot say when this person will actually experience this crisis and this hopelessness, because when they are in this dire hopelessness mode, they can have a lot of suicidal thoughts and they can actually attempt to hurt themselves. So what we need to tell them or educate them on strategies of coping behavior. How can they improve their resilience, and where can they access support or professional help? This is what we need to tell them. Okay, before they leave, we cannot say for sure that person would not attempt. Okay, but we need to tell them what can they access if they are in dire crisis. Okay, the second question, a student, depending on their age, if it's an adult student, they can actually come to us to seek help. But we actually encourage even students below age, underage students, they can actually come to Mentari. But for us, if we feel that the student, after assessment, we feel that they need to be started on certain therapy or medication, we cannot do any intervention without their parental consent. So we have to, some of the students say, I don't want my parents to be involved. So if, they keep saying that they do not want their parents to be involved, we try to pujuk them lah. We try to persuade them, we cannot start anything, we cannot do any intervention like medication without the parents' keizinan, right? So we need to work, actually the three things are ask, persuade, and refer. Okay, if we are not in the right, we do not have the right training or the right tools to actually deal with a certain problem or deal with someone who has suicidal behavior, please refer. Okay, but if they refuse to be referred, we try to keep persuading them to get assist them to get professional help. So we need to, that's why they said tanya, pujuk, dan rujuk. Okay, ask, persuade, and refer. Okay, so this is gatekeeper training, QPR. Okay, question, persuade, and refer. All right. Okay, so I think for us, if parents do not allow them, but if the student allows us to call the parents, okay, so this is what we do commonly, right? If the student gives us permission, they're adults and said, yeah, you can call my parents. We call the parents, we tell them about that the daughter needs help. We explain to them that the daughter needs help, and if they do not need help, this is what happens. It can affect their functionality, it can affect their studies. Okay, we tell them the consequences of not getting the appropriate help. So this is what we need to convince, because some of them are not convinced that the child has mental health issues. Okay, all right. Okay, yes, Mr. Kenny, ask, persuade, and refer. So easy for us to remember lah. Okay, it's QPR. Or okay, how old is someone considered as an adult? Above 18. Okay, so below 18 still underage. Okay, above 18 they are considered as adult lah in our Child Act. Okay, okay. Okay, let me see. There's one more question. Thanks, okay, for sharing. Would like to understand generally how much one session is charged? Some people think it's expensive to meet a professional psychiatrist. This thinking might block them. I agree totally, Chia. Totally agree with you, because let me tell you, in government service, okay, accessible health. Okay, so accessible. Mental health services are so accessible. Okay, for the first visit, first visit, if you are referred by a private practitioner, they charge you 30 ringgit lah, okay, if you're a Malaysian citizen. Different charges for non-resident, okay, 30 ringgit, and then subsequent follow-ups are charged 5 ringgit. This is to see the specialist. 5 ringgit per session, medications included, psychotherapy included. Okay, so if you want to see clinical psychologist, if we feel that you need psychotherapy and you need to see a clinical psychologist, it's just a flat 5 ringgit. Okay, but come and get services as soon as possible, because I think the Ministry of Health is trying to revise those charges. In Klinik Kesihatan, you need to pay 1 ringgit, okay, to get any medical help. But if there's a visiting psychiatrist to the government mental health, or if you want to see the specialist, the family medicine specialist in the Klinik Kesihatan, you are charged 5 ringgit. Medications included. In private, psychologists, they may have different charges. So we can actually type in or Google private clinical psychologist, and maybe they will exhibit the charges, or you can actually call the clinical psychologist to ask them how much is each session cost, or if they do tele psychotherapy, or virtual psychotherapy, the charges may be different. So now they are doing, a lot of clinical psychologists are doing virtual psychotherapy. So even our clinical psychologists, for those who do not want to come, they have actually incorporated this virtual psychotherapy into their services lah. Okay, so in government, very accessible, financially very accessible. Okay, so medications, no matter how much of medications you are being prescribed, it's included in that 5 ringgit after seeing the specialist. Okay, all right, thank you so much. Yeah, thank you all for your questions. If there are no more questions, back to you, Dr. Hartini.
Okay, right. Thank you, Dr. Uma, for the lovely talk. It was very informational.
Thank you so much.
And thank you for coming to talk to us. It's because this is based on the WSPD month. So we had to delay it because I wasn't actually around last
Okay.
week.
All right.
So thank you so much for all your support. And
Thank you.
if can we all just give her, like Dr. Uma, like a round of applause
Thank you,
by giving a reaction or
thank
something?
you everyone. Thank you everyone for your participation. Okay, really appreciate joining. Tomorrow is a holiday, public holiday, and really appreciate all of you joining in. Thank you so much. Fazli, I'll catch up with you.
You're right. And
thank you everyone.
thank you everyone for attending. That's all for tonight. Take care. I think it's Malaysia Day tomorrow. I think it's a public holiday for tomorrow. So everybody please have fun and take a rest for the long weekend. And thank you, Dr. Uma, once again.
Thank you, Dr. Hartini. Thank you, Mr. Kenny. Thank you so much for facilitating this. Okay, bye-bye everyone. Have a good Malaysia Day. Okay,
Bye-bye.
Bye-bye. Good night.